que as residências acabando, vai dando um frio na barriga, né?
Sim, faltam 2 meses para acabar a residência, né? E dá uma mistura de animação com ansiedade.
Com certeza. E como estão as cataratas, hein? Você vai terminar mais ou menos com quanto?
Eu vou terminar com um número bom, vou terminar mais ou menos com umas 130 cataratas feitas. E você?
Legal. Por aí também. Umas 130, 140, mais ou menos.
É um número excelente, né?
Eu acho que é bom.
Mas dessas aí, quantas foram implantes de lente tórica?
Você acredita que nenhuma?
Nenhuma?
Nenhuma.
É mesmo?
Nunca coloquei lente tórica. E você chegou a colocar?
Nenhuma.
A gente vê os preceptores fazendo, mas assim, nunca chegamos a tocar numa lente tórica, né?
Exatamente. A lente tórica atualmente é tão importante, né, Larissa?
Com certeza. E hoje em dia o astigmatismo é quase que um padrão entre os pacientes, né? Seria tão interessante a gente conseguir corrigir isso através de uma lente intraocular, né?
Sim, com certeza. E no YouTube tem vários canais de oftalmologia muito bons, né? Assim, eu consegui encontrar algumas informações, mas as informações ficam todas soltas, picadas, eu não consegui achar um vídeo bom que reunisse tudo.
Então, eu achei um vídeo bem interessante, simples assim, com a linguagem fácil de entender, que mostra desde o planejamento cirúrgico até o posicionamento da lente dentro do olho. Eu achei muito legal. Esse aqui, ó. Calma que eu vou abrir pra gente ver.
Vamos ver.
Toric IOL implantation made simple, a guide for beginners. In patients undergoing cataract surgery, 30% have more than 1.25 diopters, and 10% have more than 2 diopters of astigmatism. As we correct astigmatism with glasses and contact lenses, why not to correct it with a toric intraocular lens during cataract surgery? When to implant, patient selection. The first cases should be patients with regular bow tie astigmatism. Meridians and astigmatism among different devices should be similar, with a tolerance for up to 7 degrees for meridians and 0.5 diopters for astigmatism. Which IOL should I select? IOL calculation. Input the pre-op data into the calculator. In the IOL manufacturer website or other calculator. ESCRS and Barrett Toric are the most commonly used today. These formulas consider the posterior astigmatism. Don't worry about it. The Barrett formula allows the input of data of up to 3 devices. The K calculator of Barrett significantly increases the accuracy of the formula. I don't know my SIA, how to measure it. Surgeon-induced astigmatism assessment is essential, with calculators readily available online. Use 0.12 as the centroid for a 2.2 mm cornea incision in Dr. Hill's SIA calculator. Surgery. Where should I align the IOL? The digital marking systems are very useful for the toric IOL alignment. But do I really need those expensive fancy toys? Current literature indicates that axis marking smartphone apps can reduce misalignment with effectiveness comparable to digital systems. In this regard, iToric and ToricCam are the most commonly used apps. But how to use it? The patient should be in an upright position to avoid cyclotorsion. After anesthetic drops, mark the limbus at 0 and 180 degrees with a toric marker. Take a picture of the wide-open eye using your app of choice. Input the axis given by the IOL calculator. A new axis of placement will be provided. Make a final adjustment after placing the 2 red dots on the original marking. Another simple and effective option for pre-op marking is LaserX, a laser marking system developed by Dr. Jagdeep Kakadia in India. 2 simultaneous laser shots mark the 0 and 180 degrees meridians. Here we can see the intraoperative markings. Surgical pearls. The capsular hexis size is ideally 5 millimeters and should cover the whole optic 360 degrees. Use the round tip and short neck IOL manipulator, Yo's model. It allows easy and quick IOL rotation inside the bag. Here you can see both the regular and Dr. Yo's IOL manipulator. Anterior capsule polishing is essential to avoid late contraction, IOL decentration, and loss of astigmatism correction. Remember to leave the IOL 10 degrees from the final axis before complete visco removal. It is important to make the final positioning with the I and A after complete visco removal. Also perform viscoelastic removal from behind the IOL to avoid early post-operative IOL rotation. At the end of the procedure, leave the eye soft to avoid early IOL rotation. Special cases. Radial tear. During epinucleus removal, a radial tear at 8 o'clock is iatrogenically created. Take your time and do not remove the phaco tip from the eye until the bag and the anterior chamber are filled with viscoelastic. Perform careful cortical aspiration. Radial tear is a contraindication for toric implantation, right? Yes, but if we enlarge a bit the incision, to enter with the injector inside the anterior chamber and implant an IOL model that unfolds relatively slowly, it is possible to implant a toric IOL in the bag safely. Piggyback, toric plus multifocal IOL. If you get a case of primary piggyback with toric IOL plus multifocal IOL in the sulcus, remove all viscoelastic from behind the IOL before the sulcus IOL implantation. Then remove all viscoelastic from behind the sulcus IOL and fine-tune the final IOL position. Long eyes. Eyes with axial length greater than 24.5 millimeters should be implanted with CTR. The capsular tension ring is useful to avoid rotation inside these large capsular bags.
E aí, muito bom o vídeo,
Nossa,
né?
muito bom o vídeo.
Deu para entender agora a técnica e o passo a passo. Parece até simples,
Sim,
fazer.
fica muito mais tranquilo de entender, né?
Com certeza. Tem um paciente que eu acho que vai ser ideal para esse caso.
Vamos tentar fazer?
Bora marcar?
Bora.